just give a pause. Chitra, thank you so much for your kind introduction, and I am wishing you all the best for your new term for the next couple of years. Now, the first case that I'm going to show you is a 60 plus lady, angle closure glaucoma, status post YAC-PI, very well controlled on medications. Intraocular pressure is in the mid-teens, and she has got significant cataract. The anterior chamber depth is more than 1.5 to 2 millimeters. So I decided, can I have the video on now? So I decided to go ahead with routine cataract surgery for her under topical anesthesia. So as you see me making the paracentesis incisions, both superiorly as well as inferiorly, the anterior chamber is shallow. The MVR tip impinges on the anterior capsule. I was careful, so I did not have any damage to the anterior capsule. AC was shallow. The intraocular pressure was quite high. So I'm having difficulty in even injecting intracameral Zylocard, 1% Zylocard here. So I had to go ahead with the case for some reason. So I wanted my circulating nurse to start off an IV mannitol, 20% mannitol drip, about 150 cc in a fast drip, so that in 10 or 15 minutes time, the patient, the intraocular pressure comes down and the surgery becomes uneventful. And in the meantime, I thought that I will continue with the rest of the steps, like staining the anterior capsule, making the capsular Rhexis, as long as I'm able to avoid the complications, as long as I'm able to go ahead with the routine steps. And I'm just waiting, biding my time for the intraocular pressure to come down, for the anterior chamber to deepen. In fact, I was initially under the impression that if I inject OVD into the anterior chamber, perhaps I'll have sufficient anterior chamber depth, but it was not happening. And AC is still shallow. I'm doing a Rhexis in a very gingerly manner, making sure that the Rhexis really doesn't run out to the periphery. Now, I normally use IV mannitol preoperatively for this kind of patients if the pressure is in the 20s, or if the anterior chamber depth is less than 1.5 to 2 millimeters. But in this case, since the pressure was in the mid-teens and the anterior chamber depth was more than 1.5 millimeter, I did not give IV mannitol to start with. When you use IV mannitol, it is important that you give it 1 hour before surgery, make the patient visit the toilet before the patient comes to the theater. But anyway, so that wasn't done. And so far, so good. I somehow managed to come out with a decent capsular Rhexis, but the pressure doesn't come down. So I have to think about alternative plans. So I decided to go ahead with something that is debatable but very logical to reduce the intraocular pressure, and that is pars pana anterior vitrectomy. So I used a 23 gauge trocar cannula system to make a self-skilling sclerotomy for the vitrectomy. Now, I have trained myself. My wife is a VA surgeon, so I have watched her videos and I have assisted her, and she has assisted me for a couple of cases. So if you have not learned how to do it properly, I would suggest that you don't do this particular procedure to soften the intraocular pressure, to soften the globe, to reduce the intraocular pressure. Some people would suggest that you try to aspirate the vitreous with a thick gauge needle, but I think that is also not advisable at all, for fear of vitreous traction at the base and fear of retinal detachment. So I did the pars pana vitrectomy. I could see the vitreous cutter behind the crystalline lens, behind the cataractous lens, and I titrated with the intraocular pressure. And then once I realized that intraocular pressure is okay, I stopped the surgery. I stopped the vitrectomy and continued with the next step. So the next step would be cortical cleaving hydrodissection, which anyway the pressure goes up. So I didn't want to do it before the vitrectomy was performed. So now we need to keep in our mind what exactly was the cause for the intraocular pressure going up. All the differential diagnosis should be in the back of your mind, and you should have a decision tree ready, plan A, plan B, plan C, and everything should be a knee-jerk. You should do the right thing at the right time. So is it a patient of suprachoroidal hemorrhage? Obviously no, because we have a very good red reflex, and there is no dulling of the reflex. Patient doesn't complain of any pain. If you have the minimal suspicion of a suprachoroidal hemorrhage, it is mandatory that you don't proceed with the cataract surgery, close the incision, refer the patient to the posterior segment surgeon, who will take up the patient after a couple of weeks when the suprachoroidal heme liquefies, and that is the time where you can complete the cataract surgery. So definitely it was not a patient with suprachoroidal hemorrhage. It was it aqueous misdirection? it was not aqueous misdirection because the surge, because the intraocular pressure went up before I started any irrigation maneuvers inside the eye. I did not do hydrodissection when the pressure went up, and there was no irrigation aspiration was going on, and no hydro polishing of the posterior capsule. So that all those conditions have been ruled out. If it is not a capsular Rhexis block, because it was happened, the pressure went up even before the hydrodissection was performed, even before the Rhexis was performed. So far so good. I implanted an intraocular lens, a single piece hydrophobic acrylic lens, which went into the capsular bag. Eye is sufficiently soft, and I went ahead, and the patient did well. Another option would have been for me to postpone the surgery and take up the patient at the end of the day, at the end of the list, or on another day after giving IV mannitol. But as I mentioned earlier, for some reason, I did not want to postpone the surgery. I wanted to finish off the surgery on the same sitting itself. So making sure that the lens is well centered, and then you concluded the surgery by again having a relook at the sclerotomy site. Some amount of vitreous does come out. So as you remove the system there, so I perform a little bit of vitrectomy to remove the residual vitreous, and the congenital flap was cauterized there, and it was left sutureless, and the patient did extremely well on the first postoperative day. And so that is the end of my first case.
Actually, Dr. Kumar Arup, that was a wonderful case, literally a teaching video. But I have two questions here which I'm going to ask you together. I think you would not have had any of these problems, or maybe lesser of these problems, had you given a pre-op mannitol to this patient in the first place. Like maybe the IOP was not checked prior to the patient being shifted to the theater, although he would have been medically controlled when he saw him last in the OPD. That probability is there, because I'm not so sure about the limited vitrectomy being done by all and sundry, because there is a challenge, because this is a case, a small eye, angle closure, a PI, there could be n number of situations. You could even had a fluid misdirection and whole lot of other issues besides the pre-op IOP being high in this situation. So in this vitrectomy, if you do in these kind of patients, what can happen here is that the smallness of the eye, you might find that the anatomy of the eye, the pars plana would be more anteriorly placed in some of these situations. So you might end up piercing the retinal periphery or the lens capsule, or you could have a suprachoroidal hemorrhage. So would you advise this step as a routine? Maybe you were well trained, you had your wife who taught you, but I wouldn't say that this is approach. Probably a pre-op mannitol should have been best, or you could have waited for the pressures to come down or taken up the case the next day.
See, Dr. Chitra, but thank you so much for asking these questions. The proof of the pudding is in the eating. So the patient has done well, number one. And second thing is the complication management is controversial. There are different ways of managing the complication depending upon the surgeon's background, his level of training. So my dictum for angle closure glaucoma patients being taken up for cataract surgery is pressure in the 20s and anterior chamber depth less than 1.5 millimeter. So after this case, I've been doing this kind of cases for 20 years. After this case, I have altered my threshold. And now any patient with angle closure glaucoma, I would give them IV mannitol preoperatively. But this is still not to say that intraocular pressure may not go up. So in certain situations where the intraocular pressure goes up, so this is one of the options. And you are quite right that some surgeon, in fact, I mentioned during my video presentation too, the surgeons who hasn't learned how to do a pars plana vitrectomy shouldn't do it. And you should not even do a pars plana aspiration of the fluid vitreous, because it is said, it is easier to look at the fountain of youth than look at the fluid pockets of vitreous. So that pars plana vitreous aspiration also should not be done. So ideally, what I have done in similar cases, some other cases, I have postponed the surgery, taken up at the end of the day, after giving IV mannitol, or taken up on the next day, and patient has done extremely well. But there are a lot of teaching elements, and as I mentioned, complication management is always controversial. Different experts have different ways of managing things, and I thought it will be quite beneficial for the viewers to get exposure to this discussion.
So we shall go on to the next video now,
Just
because we're really running short of time.
Dr. Arup, what
was all the questions for
just one or two which have come, which are very quick to answer. What was the anesthesia that was used?
Topical anesthesia.
So you did the vitrectomy also under topical anesthesia.
Yeah. And so if I may add a point here, I mean, all my patients are under monitored anesthetic care. So midazolam is given, the anesthetist is standby. And if some patient has a problem, then I would use a pledget of Vexel or a pledget of cotton wool soaked in proparacaine, and just apply it around the area of the sclerotomy. Or sometimes you can even give us just subconjugal injection of xylocaine 2%. And the patient, this particular patient is very cooperative, so nothing else was really necessary.
I think if I can just say one small sentence is that as a phaco surgeon, I think all of us definitely need to get trained in doing a pars plana vitrectomy, especially when you're faced with situations of posterior capsular rent. And as Dr. Arup said, this is also a situation which many of us face at some time, that the eye becomes hard, not just in cataract, but in different kinds of surgery. Sometimes when I do a PDEK, I get that. So this is a safe procedure actually in those situations where you can go in and do a pars. So please definitely get yourself trained for doing this.
So we shall go on to the second video of Dr. Arup, which is also going to be a learning in itself.
Yeah. So please give a pause before starting the video. See, the next case that I'm going to show you is cataract surgery in a post-vitrectomy eye. I must tell you that most of the surgeries in post-vitrectomy eyes are routine, because majority of the cases have undergone vitrectomy for macular hole surgery, for epiretinal membrane, or just simple vitreous hemorrhage. And those cases, when you see on the screen, doesn't appear to be any different from that of a routine case. But on the other hand, if you have patients who have undergone repeated vitrectomies, vitrectomy around the vitreous base, silicone oil injection, so those cases become challenging. And let me show you one such case. Can I have the video on? Please put it on.